Hello, yes, I'm Neil Sheerin. I'm the Professor of Nephrology at Newcastle University and one of the consultants in the HUS service. I'm going to talk to you today about some of the work that we're doing in relation to stopping eculizumab treatments for patients who have atypical hemolytic uremic syndrome. So, one of the important things to emphasize is that eculizumab is a very effective treatment for patients with atypical hemolytic uremic syndrome. And over the course of the years, several studies have been published to show that when we use eculizumab to treat atypical hemolytic uremic syndrome, we see a very good response to treatment. However, there are a number of unanswered questions, and one of those is what is the best way to use eculizumab to treat atypical hemolytic uremic syndrome, and particularly relating to what happens in the later stages when the disease is perhaps in remission, but people remain on treatment. So what I'm going to talk to you today specifically about is a trial that we're doing called the SETS trial, which is looking at this specific question. The first thing to consider is, why do we need this study? Well, one really important thing is from a patient's perspective. And when patients were asked what are the important questions that they want to know about their treatment, they asked, can a complement inhibitor be stopped safely when not needed by some patients with atypical HUS, and what makes those patients different? The second important reason we need this study is from the opinion of NICE. Now, NICE, as I'm sure you'll be aware, is the body of in the UK that decides what medicines can or cannot be used. And when NICE considered eculizumab, one of the recommendations that they made was that there was a research program with robust methods to evaluate when stopping treatment or dose adjustment might occur. So this study is to try and fulfill those two important drivers. Let's think about it a little bit more as to why we need this study. Well, there's a relative lack of evidence of how long people need to stay on treatment. The original studies which described the efficacy and the effect of eculizumab in treating atypical HUS was only for 26 weeks, so only for 6 months treatment. But we now are starting to get more and more information that perhaps continued treatment isn't necessary, which is what's currently recommended. And several studies have been published, or several series have been published, mainly from mainland Europe, describing discontinuation of treatment in patients successfully treated. And this was the first one that described 10 patients who came off treatment. Now, 3 patients did relapse, but that does mean that 70% of the patients, or 7 out of 10, who came off treatment were able to stay off their treatment. So, reasons for the SETS trial is there is a lack of evidence about how long people need to stay on treatment. And we estimate that perhaps over half of the patients who are currently receiving eculizumab treatment will be able to come off treatment. There's also the burden of treatment. As many of you will know, eculizumab is delivered by intravenous injection, usually every 2 weeks. So that means that, for the rest of your life, potentially, people will need to carry on with regular intravenous treatments. And that can be particularly troublesome if you've got poor veins, and also particularly in children. There's also, if you can come off treatment, the potential to avoid complications associated with eculizumab treatment. We looked at the first 100 patients who were treated with eculizumab, and we identified 6 relatively serious complications which we thought were either definitely or likely to be associated with eculizumab treatment. And that was mainly infection with meningococcus. Meningococcal infection is very serious, causes meningitis and sepsis, and is very much increased in patients who are on eculizumab, perhaps up to 1,000 times from the US series. There's also the cost of eculizumab. Eculizumab, as you will know, is a very expensive medication. And in the context of the SET study, if we are able to stop 50% of patients, which we think we will be able to do, then we're perhaps saving somewhere in the region of £11 million for the NHS. And that's only over a 2-year period of follow-up. We're also very aware that prior to the SET study, some people were coming off treatment, and this was in a relatively unsupervised, unstructured way because there were no protocols to tell us how best to withdraw treatment. So part of the thing that we're doing within the SET study is to try and identify what's the best way of monitoring patients once they withdraw from treatment. So SET study, it's funded by the UK government through the National Institute of Health Research and is supported by the hospitals here in Newcastle. So what are we actually doing? Well, we're looking at withdrawing treatment from 30 patients who are currently receiving eculizumab. Now, this is just to really emphasize one point. This is some of the patients that have been referred to the service here in Newcastle over the last 4 years or so. And we do withdraw treatment from a significant number of people anyway. But these people here are people who we feel have a reason to stop. So we think that the treatment is either the wrong treatment or it's not working, or we think that carrying on treatment is for no benefit to the patients. What the SET study is doing is looking at the people who we think do have atypical HOS, who we think have benefited from eculizumab, and under normal circumstances would continue treatment, but we actually feel it may be worth investigating whether or not they could stop. And this is the group in the left-hand side of this figure. So, as I mentioned, 30 patients. Those patients will be very closely monitored by a series of hospital visits and home testing, and we plan to rapidly reintroduce treatment if a relapse were to occur. So how do we do this? Importantly, when we're designing clinical trials, every trial has to have an endpoint, and that tells us whether the investigation that withdrawing, in this case the withdrawal of eculizumab, is effective and safe. And that tells us, as I said, whether what we're doing works. And part of what we do at the end of the study is we decide whether the trial has met its primary endpoint. And in the case of the SETS trial, the primary endpoint is harm to the patient. So we're looking at very carefully everybody involved in the study to see whether they are coming to any harm. And if patients are coming to any harm, that's meeting the primary endpoint, and that would be a reason we'd have to consider whether it is actually safe to withdraw treatment. How do we judge that? Well, we use this technique called Bayesian design. Now I'm going to briefly just describe what that is. So we use a grid format. So when a patient enters the study, if everything goes well, we move down one of these boxes. If the second patient also does well, then we move down the second box, and so on. So if everybody entering the study does well and has no problems, then we move down until we hit green. And if we hit green, it tells us that it is safe to withdraw eculizumab. Now, there is an alternative, and what happens if a patient comes to harm? Then if the patient comes to harm, we move sideways across the grid until we hit the red. And if we hit the red during the study, it means that it is not safe and the trial would stop. In reality, what we're likely to see is perhaps occasionally one patient may come to harm, and there may be one person moving across on this grid. Can we justify anybody coming to harm during this study? Well, we feel that it is possible to justify it because of this. Because even if patients stay on treatment, there is a risk of staying on treatment. So unfortunately, when you have a disease like atypical HOS, either being on treatment or potentially coming off treatment is associated with a risk. What we probably will see in reality is, that we'll get through this grid, we'll get to the bottom at the end of the study, and then we'll be able to say that staying on treatment is at least as safe and perhaps even safer than staying on treatment. There are other parts to the SET study as well as just looking at safety. We're doing two other things. We're looking at health economics, so we're trying to understand the relative cost implications of staying on treatment as opposed to coming off treatment, and that will involve an additional 20 patients who stay on treatment but complete a series of questionnaires during the study to understand the impact of the treatment and the disease on those individuals. We're also doing what's called a qualitative study. Now, what a qualitative study is a series of interviews where we ask people of their views, their anxieties about participating in the trial, coming off treatment, or staying on treatment. So we understand more in detail what it involves, how it affects people, how the disease affects people, and how the treatment affects people. So where are we now? So we opened the first site for treatment withdrawal in December of 2018. We now have 14 sites across the country which are currently open, and 21 patients have stopped treatment. During the course of the trial, 3 patients have had to restart treatment, and they've restarted treatment successfully without any harm coming to the patient. So 21 patients have stopped, 18 remain off treatment. So we're looking at somewhere in the region of 80+% of people being able to stay off treatment according to the trial so far. And even those patients who've had to go back on treatment have done so safely without any harm coming to them. So where do we feel that this will lead us? I think we hope to be able to show that it is safe to stop treatment. We will hope to be able to show that we can rapidly detect any signs of a relapse and try and introduce treatment quickly. And our goal is to be able to reintroduce treatment within 24 hours of any suggestion of a relapse. And what we really want to be able to do is to be able to more effectively use what is a very good treatment for atypical HOS. So this is really where we are currently. So if disease occurs, according to the license that's available for eculizumab, a patient will have the diagnosis, will start eculizumab, and will potentially carry on with treatment indefinitely, possibly for the rest of their life. What we see that the SET studies and similar studies will provide is a choice and different treatment strategies. So occasionally, patients, when they develop the disease for reasons either due to genetics or due to the severity of the disease, we feel that they may need to stay on treatment for the rest of their life. However, some patients, when the disease happens, will be able to go on to treatment for a period, perhaps 3-6 months, and then will be able to withdraw for treatment and then potentially stay off treatment for the rest of their life. There'll be a third possible option where a patient will get the disease, go on to treatment until remission is induced and the patient is well. They will then be able to come off treatment and stay off treatment for a period. Then there may be a relapse of disease, in which case the patient will need to go back onto treatment for a period of time, but they may well then be able to withdraw again. And particularly if this period between the initial onset and the relapse, we could be looking at years, potentially even decades. So there'll be a strong rationale, therefore, for coming off treatment again. So what we hope to be able to do at the end of this study is to offer patients choice, and not necessarily, once they start treatment, remain on treatment for the rest of their life. So just to sum up, eculizumab is an effective treatment for atypical HOS. It controls the disease rapidly and effectively. But we also know that patients can go into remission, and probably when on treatment, the disease can just go into remission and be no longer active. But the patient's on treatment, so we don't know whether the disease is actually in remission or not. But in those patients who are in remission, I think it's fairly clear now from SETs so far and from other studies that eculizumab can be safely withdrawn. The data in the literature and also our current data would suggest that at least 50% of patients can withdraw. So a significant number of people on treatment could come off. There do seem to be getting a pattern where people who have a genetic problem with factor H may be more likely to relapse than others. So that is something that we're looking at within the context of the study. I think it's clear that close monitoring will be very important in order to pick up relapse quickly and effectively restart treatment. And what we hope to end up is that we'll move towards a protocol that is based on intermittent treatment of an acute relapse rather than prophylactic treatment, maintaining treatment for patients longer term. I hope that's been informative and to let you know what we're doing at the moment. If you want any more information about the SETS trial, please do contact us on the email of atypical.hus@nhs.net, and I'd be very happy to discuss the trial further with individuals or their clinicians. Thank you very much.